Hour. This is Beth Armstrong, and I am NASEMSO's Management Council, and I am very excited that I get to make announcements to introduce today's session, starting with the reminder that all these sessions are going to be recorded. And I'd like to give special acknowledgement that today is National Emergency Nurses Day. So I think it's appropriate to express our deepest appreciation for all the nurses working in EMS. Thank you for your hard work that supports our greater good. And thank you for that sound effect. All attendee lines are currently on mute, and as we did yesterday, we will unmute all the lines for interactions with presenters at the end of the session. We have established a new YouTube channel to share the videos of this week's recordings, and the link is posted on our website. It does take a few days to edit and upload the recordings. All PowerPoint files either are or will be available on the NASEMSO website as well. Just look under NASEMSO Reimagined 2020. So we do have a revised agenda for today, and if you are here, you have detected that this session will address NEMSIS, and we are currently in NASEMSO's meeting room A. I don't know if that means anything to you, but the GoToMeeting link that you clicked brought you into meeting room A. It's in effect through noon tomorrow for the panel Reinventing EMS. But then tomorrow afternoon's business session at 3 p.m. will be held in our auditorium, which is a different link. And if you need a copy of that link, let us know. And if you are interested and are a state director with a voice in vote and want to send a proxy for the business meeting, let me know. And then finally, Friday's State Directors Networking Session is by invitation only. It appears on the agenda, and we distributed a link to the directors. If you can't locate it, let us know. So Dr. Mann, if you don't mind, I'd like to ask you to make a self-introduction and introduce Eric Chaney for our NEMSIS remarks.
Yeah, happy to do that. Thank you, Beth. It's a pleasure to be here with you folks and to talk about NEMSIS. This has been an incredible year for creative uses of EMS data. So it's a great opportunity for us to talk about what's happened, what's been successful, and what has not been as successful as we'd hoped. Let me begin by introducing myself. So my name is Clay Mann. I am a professor in the Department of Pediatrics at the University of Utah School of Medicine, where currently the NEMSIS Technical Assistance Center is housed. My project officer, Mr. Eric Chaney from the Office of EMS at NHTSA, will also be participating in this presentation at the end, giving a national perspective in regards to what's going on with NEMSIS. If we can go ahead and begin with the slides, Hannah, if that would be okay. With the PowerPoint. Great, thank you very much. All right, so let's go ahead and dig in. If you'd move to slide 2, that would be great. We have a lot of topics to cover, as you can see on this slide here. We want to talk about the current composition of the National EMS Registry. So that sub portion of data that is associated with every EPCR that comes to the National Repository. What is that looking like right now? And what is it being used for? Let's talk about that a little bit. There's been lots of clamor about ET3. Let's talk about how we've been doing lots of extensive work trying to ensure that NEMSIS data could meet the needs of the ET3 model evaluation. I completed a lot of work to support COVID-19 in regards to our EMS providers, making sure their data collection was appropriate, and also provided other types of support tools. We'll talk about that. That work has led to an increased interest in perhaps modifying the state data use agreements that the NEMSIS TAC maintains with many states to allow for some identifiers to be released for surveillance purposes. That's only in the development stage, but we'll talk about where we are with that and if folks think that's a good idea. Promoting bidirectional data flow. EMS continues to provide nice avenues for data to flow from EMS to EHRs, for example, in hospitals, but the back return of data, patient outcome data back to EMS has been difficult, but there's been some great developments this summer that will help with that in the future. Let's talk about that. And then under the direction of Mr. Eric Chaney, we have developed some special interest groups with special expertise to help the NEMSIS TAC to increase our effectiveness and efficiency. Talk about that. And then what's in the near future for the NEMSIS project? Let's dig into those. There's a lot there to cover, so let's go ahead and dig in. Next slide. In regard to the current composition of the National EMS Repository, it just continues to be an incredible resource, and states just, and our providers, our clinicians across the country, work so incredibly hard to make an incredibly rich data set, probably the largest healthcare registry data set outside of federally funded CMS records, clearly the largest data set. We're currently collecting data from 48 states and territories, and I highlight there with circles on that small US map, both Ohio and Missouri that are within days of beginning to submit to the National Registry, so that I'm looking at 50 states and territories. So far in 2020, we have collected over 37 million EMS activations from across the country, which is just incredible. We are so close to a complete census of all EMS activation across the country that it's impressive. And to kind of maybe highlight that a little bit, we have several folks across the country that are utilizing large data sets and machine learning to actually do some great things with NEMSIS data. And those folks are utilizing NEMSIS data that goes back to 2010 through our mid-year data set that we released for 2020 because of the COVID outbreak. And those folks are literally working with 250 million EMS activations to do that type of machine learning. So it's just been an incredible journey for NEMSIS, and the folks on this call and others who can't be with us have worked so incredibly hard to make this all work so well. One of the incredible parts of the NEMSIS data collection, of course, is that records are available very quickly. So right now, as of today, we receive about, in the National Repository, we receive about 75% of all the EMS activations that occur on any one day within about 2 weeks. So the data set is not a year old, it's not months old, it's really about 2 weeks old, which is just incredible. One last milestone that we recently passed is there are now over 1,000 publications using NEMSIS data in Google Scholar. So great progress in regards to the composition of the registry and really how often it's being used. Let's move to the next slide and talk a little bit about our current work with ET3. As folks know, ET3 is getting underway. It will officially start as of January 1 of 2021. And we've been working very hard with CMS to ensure that they can utilize NEMSIS data to meet all their needs, to be able to evaluate the different models that they're going to be working with within ET3. I'm just going to highlight some of the things that we've done to make sure that that data stream to them is as efficient as possible and as correct as possible, so that there can be a good evaluation of that model. I begin here by just pointing out that we have a NEMSIS custom element library where every state can place in there custom elements or custom values that they develop that go beyond the NEMSIS standard to meet specific needs. And you'll notice if you go to the NEMSIS website where that small circle is there at the bottom of this slide, you'll see that there's a little blue box there, ET3 project. Next slide. That's where you will find the custom element and values that have been developed to ensure that we can correctly classify ET3 related calls in patient treatment, whether that be transport to an alternate destination or treatment on scene. Custom values have been added to the existing eDisposition 12 an e-disposition 21 to describe those type of events, and then a special element was added to be able to measure whether or not an alternate disposition was offered to the patient, and how did the patient respond to that offer. So we've really been able to use NEMSIS data as it stands, except for these small modifications, to be able to properly evaluate the ET3 model. Next slide. Folks familiar with NEMSIS will know that we rely heavily on what we call schematron files that are just full of business rules to help our clinicians ensure that they're providing quality data. There's an ET3 specific schematron file. You can see it listed here. Those familiar with our business rules, they can either be errors, in which case a record will not flow, or they can just be warnings, and so a record can be exchanged and moved from an EMS agency to the state to the national level, and in this case, to the CMS servers. All of the additional business rules that are associated with the ET3 model, they're all warnings, and so the data will always flow. All the records will flow into the CMS enclave. Let's go on to the next slide. Let's talk a little bit about how we've defined the data flow for ET3. So in this complex model, and I apologize for that, there's a lot of information that we wanted to make sure was clear to vendors as they're preparing to shift some record flow into the CMS enclave, how they could use NEMSIS data. So you may look at the little characterization of an ambulance, and then from the bottom of that, line C3 and 4B, this is the traditional exchange of records, right? This real-time web services record exchange we talked about that keeps the NEMSIS data set so timely. This is the traditional approach. And you can see that we're not, the ET3 flow of data, which is the C5 series, or 5C, 5B, 5A, you can see that flow of data is completely different from the flow of data that is traditionally completed once a record is done. So we're not disrupting NEMSIS flow. We're not disrupting any flow of data to the states. It's just turning on another pipe, turning on another avenue for the data to flow into the CMS enclave. And if anybody has any questions related to any of these things, feel free to ask those in the chat. I'd be happy to address them. So that's been a real win, right? That we continue to receive our data, the states receive their data, the National Repository receives the data, and all we've been able to do is use like 99% of the existing NEMSIS information flow to really be able to provide CMS with all the data that they need. There have been questions raised by states as to how the states will relate to those agencies that are participating in the ET3 model. If we could go to the next slide. We held a question and answer kind of hour period with state EMS officials yesterday and tried to answer a lot of those questions. It was a very productive call. Next slide. The result of that call and some pre-work that we did resulted in a 4-page document that just lists a number of questions that states have raised, and then the answers. These documents, or this document, can be found on the NEMSIS website, and in fact, I sent them over to NASEMSO, so those documents should be made available to this group as well. The ET3 data flow document that I showed just a moment ago, and then this document with Q&As for states should be available from NASEMSO. And so feel free to access those. So just one last slide, if you go to the next slide, related to the ET3 model, is we're currently, as of today, actually, beginning to onboard software companies to ensure that they have the proper security keys, they have the proper connections to be able to, on January 1 of 2021, be able to submit data to CMS for agencies that are participating in ET3. So that We're working with software vendors this week and into next week to ensure that that process is in place. And there'll be other opportunities for vendors to test their products in November and also in December. So that should be very, very helpful. So yeah, a lot is happening in regards to E3. This will be an incredibly important project and model test for our industry. So we've been very excited to be able to support it. Let's move on to the next slide and then move into another topic that I wanted to cover with you today, and that is what has been accomplished in regards to NEMSIS and modifying it and tailoring it to allow us to properly evaluate our response to the COVID-19 pandemic and epidemic here within the United States. I'll just begin by mentioning, and hopefully you can see on this slide, I know it's a little small, I apologize. If you go to that same NEMSIS v3 custom element library that I showed before, now I've moved that little red circle just away from the ET3 project on the bottom there over to national custom elements. And so this was our first kind of need to develop custom values or custom elements that could sit on top of NEMSIS that were really important to the entire nation. And so this was our first attempt at doing something like this. And you can see there on your right, the additional elements that we developed very early on when community spread was just beginning in March and in February, asking travel questions, asking recent exposures. Those were all hopefully utilized by your state vendors and the vendors that work within your field to ensure that we could collect that data. And then there was also additional values that were added. If you look at the bottom right, you can see we added additional PPE and types of destinations and pre-alert information in hopes that we could properly classify the cases that we were collecting in regards to influenza-like illness symptoms to begin with, and then potentially patients who had been confirmed to have COVID. Related to that, in the next slide was another really big project we entered into called EMS by the numbers. Hopefully many of you have seen this report. It's basically put out every week where we track EMS activations associated with influenza-like illness and have tried to provide a running kind of trend as to what's happening across the country in regards to these types of calls. Here I just show you a quick look at the amount of data that's received here at the NEMSIS Technical Assistance Center. You can see in those upper bars, the green are the successful submissions to us. The red are the ones that weren't successful. Those are mostly associated with 2 states that have been testing data, Missouri and Ohio. But you can see on a daily basis, we're receiving between 120 and 170,000 EMS activations. So across this 13 days, you can see we received over 2 million records just for the 13 days. If you forward to the next slide, I think it'll add a little red box or blue box. Yeah, there. Yeah, thank you. Can you go back one slide? Yeah, just the blue box around that lower half there. I wanted to point that out just real quickly. So here's where we track how quickly, what's the lag before we have the data associated with any specific day, right? So how long does it take before we have 25% of the records that occur on any given day? And you can see that's about 25 hours. So really within a day, we have about 25% of all the records that occurred yesterday. And you can see if you get to that 75%, I mentioned it, it's about 336 hours, which is about 2 weeks, right? Before we have a good representation across the entire US of the EMS activations on that day. Let's go to the next slide. But here's where we've been tracking the count of EMS activations that are occurring in this country. I'm just going to show you a couple of slides from this EMS by the numbers because there's some interesting trends even in relationship to today that are really worth looking at. So here's where we track or have been tracking the count of 911 initiated EMS activations where there was patient contact, the total number of records that are submitted here to the NEMSIS Technical Assistance Center. And you can see the y-axis is in hundreds of thousands, and then the x-axis is weeks, right? So you can see the blue line, for example, begins with the 40th week, or about the beginning of, the end of September, the 40th week of 2017, and then it tracks it all the way forward to the 39th week of 2018, right? So you can see that the x-axis covers a strange time period, but it is a full year. And it's strange like that because we wanted to ensure that we were capturing the influenza season correctly on this chart. So as you can imagine, influenza starts now and it runs through about the end of March. But here we're looking at the number of records that we've received for each of these year periods, and you can see those on the top left on the legend there. And they're different, right? We're getting more records with each year. That's just because more states are coming on, and states traditionally come on with the beginning of the calendar year. So you can see that really abrupt increase in the number of records with the first week of January, week 1. And that's just because additional states will wait and they'll come on with the calendar year. But what is truly interesting here and true just of this last 3 weeks ago, right? We hold the data for 2 weeks, just like we talked about before. So the 39th week, we're now in week 42. But what's interesting is you can see we really hit a low in the red line. You'd expect that just to stay separate from the other 2 lines because we had more states come on to NEMSIS data collection. But wow, we really hit a low in the number of calls that we're initiating an EMS response for. Well, week 17, week 16 into March, we really hit a low. Interestingly low, look across and you'll notice that we are now at another record low for the number of 911 responses across the country. So this speaks directly to our agencies that are really struggling with call volume and trying to keep financially afloat. It continues, even though it got better for a short period, it is back to as bad as it's ever been. Next slide. Here I'll just show you one other slide that's present in this EMS by the numbers. Here we're just tracking the percentage of all 911 activations with patient contact where the patient actually had influenza-like illness symptoms. And so you can see the percentage of all EMS calls across the country. There you see the peak in past years for the influenza season, right? So it begins at about week 40 and it ends in about, I don't know, the 8th or 9th or 10th week into the next year. It begins to fall off rapidly. But here, with week 10, it was the first week that the CDC reported community spread of COVID-19. You can see we had an incredible increase in the number of calls associated with ILI symptoms. And week 12 is where the states began to close down with stay-at-home orders, and then they began to open up about week 19. So you can see that we had a precipitous drop off, almost as steep as the increase. And then there's just a couple of lines that mark Memorial Day weekend and Labor Day weekend to kind of keep us clued in to what's happening in regards to ILI type calls that could potentially be COVID or other things. And so there's been some incredibly valuable trending here that's been important for us to be able to track. Well, related to that, let me just introduce you to 2 more things that we did to kind of help our providers to be able to communicate their needs and their resources regarding the COVID-19. If you go to the next slide, under the direction of the Office of EMS at NHTSA, we developed a resource reporting tool. And if you could go to the next slide, called the EMS COVID Resource Reporting Tool. And here, this is on the NEMSIS website. Let's see if we can get this slide to forward, Hannah. We go. Oh yeah, there's the lines. Oh yeah. If you go back, yeah, thank you. I apologize. There's a week 10 where community spread began. Week 12, states closed down. Week 19, states began to open back up, and then the orange line is the Memorial Day weekend, and the green, bluish green line is the Labor Day weekend. But there you can see the important associations with this crazy year of ILI related EMS activations. All right, let's go to the next slide. I apologize for that. All right, so the next slide introduces this COVID reporting tool. Hopefully within states, if you do not have a reporting tool for EMS agencies to report shortages in PPE or stress they may be encountering related to COVID-19, this is available even today. And this is the short, I don't know, 3-minute reporting tool that they can complete on the NEMSIS website. And if you go to the next slide, that data is fed into a reporting tool that each state has access to, and it's updated every Tuesday morning at 6 a.m. Mountain Time and Thursday morning at 6 a.m. Mountain Time, and provides each of those states with agencies participating, whether or not there are agencies, their agency name, which is blurred out, a phone number and a contact name, and you can identify agencies that are experiencing any shortage in PPE by the categories you can see here by the donut charts, or are you experiencing personnel shortages this week, as you can see there, and what number of your EMS workforce has either had an exposure or is a confirmed COVID case. This is made available to each state. This is the national view, so this is what the Office of EMS and Mr. Eric Chaney can look at every day. But if I were, for example, Utah, I could come in here and find all the agencies that are reporting shortages, and I'd have a phone number and a contact name to be able to reach out to them. So I think this has been incredibly useful. I pulled this off the website Tuesday morning, so we had over 100 agencies report on Monday. And if I were to go in there now, when it's updated tomorrow at 6 a.m., we usually see between 300 and 400 agencies using this tool. Let's go to the next slide. So this will identify one last tool that we made available to federal sources. There were 40 states, which was just incredible, 40 states that were willing to allow a extension of their data use agreements with the NEMSIS TAC during this national emergency, to allow for trending of ILI activations within their states. The value of this, and I've blurred it a little bit just because I want to protect those 40 states who provided this data. This shouldn't be publicly available. It's only available within those states. But the value was, it was valuable for you to be able to look at neighboring states' data that you in the past couldn't look at, and see if you had a neighboring county that had a larger than expected number of ILI patients for any given week. So this has been tracked by week. States have used this a lot. Some states use it every single day to be able to track their ILI patients. And then just finally, one last thing that we were involved in, I think were helpful, and let's go to the next slide, is there were several federal agencies that reached out to us through the Office of EMS. Dr. John Kramer and Mr. Eric Chaney worked extensively with these groups, and of course, Dr. Kramer was the lead for the HHS Healthcare Resiliency Working Group specific to EMS and pre-hospital. But they reached out and said, "Oh my gosh, you've got this great data set that's fairly timely. Could we use that data to help at the federal level track the spread of this virus, to provide good information regarding PPE, other things like that?" So we did what we could under the protections of the data use agreement. So Here on this slide, you can see the data that we released to FEMA and CDC. We released this data by building them an API, which means we built a way for their machines to reach out to our machine every morning and get the records, that 120 to 170,000 records that we collect. They could download that automatically every day and make it available to HHS and CDC and others who were so involved in March and April and May in being able to track what was happening. But what you can see, if you go through those list of elements, all would be incredibly helpful to them. But under our data use agreements, there was no way to assign a geographic location. The closest you can get with our public data, which is what this is under the data use agreements, is census region. So though this was valuable and this API was used early on, interest was lost because it really wasn't possible based on our data use agreements to drill down and determine exactly where these cases were occurring. So again, really a limitation of our ability to use NEMSIS data at a national level. And that leads me to the next section we wanted to talk about, if you can go to next slide, is this renewed interest of potentially relaxing the data use agreements that are in place with states to allow for some release of data for surveillance purposes. This is just a snapshot of the DUA that we have with states. Next slide. There's a number of states that utilize this data use agreement. And you can see here the arguments for this data use agreement being so conservative is it protects from kind of release of data based on a geographic area, based on a state or a county that, you know, some information may be awkward, right, if it's reported by media releases and other things like that. States, of course, have interest in controlling their data. That makes sense. And based on these concerns, very early on when these data use agreements were first developed, we kind of had to, we wanted to include all states in this data collection, so we had to accommodate this lowest common denominator. So next slide. Really, what this points out is this policy ensures that no geographic identifiers, they're in blue, no geographic identifiers, including this, even the state that submits the data, can be released. And so it is never relieved in its native form. Next slide. The ramifications of this have been that, and we've talked about this before, about 70% of the requests for NEMSIS data for research, either through public researchers or through government sources, about 70% of those requests want to have a geographic identifier, and we have to either deny the request or dilute it so that they can't actually view the data by any geographic identifier. So the little picture you see at the bottom, which is commonly associated with CDC reports, we can't do that. We don't release that data. It's interesting to note, though, that there are corporate entities that now are selling back to federal sources and to others that very data that we do collect at the national level, because we do collect state and county, but we don't release it, are selling that back to sources and have accessed that from many states based on different data use agreements. And so we're kind of in an awkward situation, I think, where we could help lots of programs be effective and help our citizens without there being a charge. So as I mentioned, CDC, HHS and others, they're handicapped in their ability to use the data, so they really are somewhat disinterested with NEMSIS data just because it can't be used for their purposes. Next slide. So the idea was to, oh my gosh, can't we develop some way, maybe just a separate data set at the national level that only looks at certain time-sensitive issues or viral infections that could be important for surveillance? Could we just develop a subset of data that could have some geographic identifiers that could be released to researchers and to federal sources. Next slide. The idea would be that we would release these elements, right? So the date and state and county, and for these time-sensitive issues in this special data set, we would only include patient complaints, symptoms, injuries, provider impression, and the only treatment-related value that we would release would be the use of naloxone, just because that has been such an important proxy for potential opioid overdose. What we would not release in this special data set is, next slide, is any information related to the patient. None of the zip codes that we collect. So we collect 3 zip codes at the national level: incident zip code, patient home zip code, and hospital destination zip code. Those would never be released, as they never are now. Wouldn't release any agency information, no EMS response times, no patient care information other than what I noted, no performance metrics, either in the system level or provider level. Nothing like that would be released, only the information on the previous slide. Next slide. We've been working with the NASEMSO Data Managers Council to work through this idea. Could we really come up with this subset of NEMSIS data that could just help our citizens by providing a way to hotspot things? And they, of course, have had reservations that we're trying to walk through on a constructive, one-by-one basis. Here's a number of them that we've been talking about. If you release county level data, you might be able to identify an agency or a hospital. What are you going to do in NEMSIS with this idea that if you have a 2-tier system, you kind of get 2 records in NEMSIS, right? So you're not surveilling people unless you control for that, right? Because it will always look like there's more cases than there actually are. So there's ways around that. We've been talking about that. Many states have mentioned you'd have to implement a small cell suppression. How would that look? And the other idea is, should states have the ability to approve requests for this special data set? So those are the things we're working through. And the next slide here will just indicate some of the progress we've made. So the Data Managers Council is working on an NASEMSO resolution that will hopefully address these issues and describe and characterize this idea of a specialized data set that would be released. Then point 3, you can see there was also this idea, well, if you just make this available through an API, right? So if you're familiar with the way that CDC releases data through CDC Wonder, just a way for people to access the data, could you have a secure password associated with that? And then states could grant permission to have that data released based on an individual review of each request. So we're just working through some of these ideas and how could we provide small cell suppression, right? If you want to check by day, some rural areas may have less than 10 for long periods of time, where in fact, for example, ILI type symptoms or known COVID exposures of less than 10 for a rural area could be very important, right? So we're still working through some of that. So that's that idea and kind of where we're at with that idea of releasing data. So just a couple of other small things I want to mention just real quickly. Go to the next slide. I mentioned we're really excited about now promoting another approach to bidirectional data flow. So folks who are familiar with NEMSIS know that we've been working through HL7 and have developed some implementation guides for hospitals to develop ways for a patient care report to leave an ambulance and get into the medical record of the patient at the hospital before the patient arrives, or while EMS is completing a record there in the lobby or something, and have that just electronically flow. Well, that's worked kind of well through HL7, but this summer, with the release of the 21st Century Cures Act, which just became law in July, there's now a whole new structure for the interoperability standard of data. And one of those things is the US CDI, the United States Core Data Interoperability Standard. We're going to be utilizing that and associating and harmonizing NEMSIS with that, and be using a new technique called FHIR. That's not so new. It's in version 4, but actually it's a more appropriate approach to the way EMS data could potentially be exchanged between hospitals and outcome data coming back to EMS. So we're going to be developing an HL7 FHIR version 4 implementation guide for the sharing of NEMSIS data. Then probably the most important thing related to this that's worth mentioning is the vendors have got together and decided, hey, this handshake between a hospital and an EMS agency is not working, right? We can't easily, without lots of money, be able to develop this approach to where patient outcomes could come back to our providers so they could evaluate their care. And the way that the vendors have decided to kind of come together and see if we can reduce the cost and the efficiency of this is to build our own kind of template of what we'd like to see back for agencies' use, for states' use, and a very limited data set for the national level. Let's just build that half of the handshake, have all vendors, EMS vendors, commit to utilizing that for this half of the handshake, and then go to the Cerners and go to the other EHR vendors and say, hey, here's the standard for all of the EMS industry. You just have to build to one standard and see if we can make that work. So that's work that we'll be completing this year. One of the other things that we're doing this year, and if you go to the next slide, is we've developed some 2 expert panels, kind of an internal board and an external board that will be supporting NEMSIS and ensuring that the NEMSIS TAC is getting good representation of the ideas from the entire scope of the EMS industry. And Eric, do you want to talk a little bit about the development of these 2 boards? I know that this was you were very passionate about the development and the kickoff of these 2 boards.
Oh, feel free, Clay. Go ahead.
Oh, sure. So the idea was, of course, as I just briefly mentioned, how can we make sure that what's happening within the TAC is really what the environment needs? So 2 boards were put together. One we're calling an internal board. It's really a group of experts that can help us ensure, all the way from researchers to medical directors, all the way down to providers, 3 providers on the board of the internal board that will help us ensure that the data, the actual elements that are collected, that there's quality data collected, that there's clarity, that the elements that are collected are used and of value, and that there's more efficiencies in the way data are collected by our providers. Can we just ease the process, reduce the burden of data collection? And then the external board is really designed with folks that have a great expert understanding of data exchange, right? How can we ensure that NEMSIS data is interoperable regardless of who's requesting it? So there clearly are strategic targets where we want to make sure data is exchanged. We want EMS providers having patient outcome data back so they can evaluate their care. We want to make sure that our data are ending up in medical records, right, at doctors' offices as well, and in clinics and in urgent cares and in hospitals to improve the value of EMS care. Anything else you'd like to say about those groups, Eric?
No, other than just to emphasize that, especially the internal board with the data quality issues is heavily weighted with the EMS personnel as the biggest population, and we picked people specifically who are not aligned with any particular organizations or any particular products. And we looked at ALS and BLS personnel because we want the provider's perspective on EPCRs and data collection.
Yeah, thank you, Eric. And then one more thing, just the next slide. 2 more quick slides. Thank you. Thank you so much for your patience. On the next slide, another development within NEMSIS that was incredibly important to Eric was this idea of having a monthly report that could be made available out to states and to other stakeholders to kind of take a look at what happened within the NEMSIS TAC in the last month. And if you could go to the next slide, Hannah. This is just an example of the September monthly report that came out. Hopefully you're seeing this. I know Eric distributes it broadly, and so this would be a great way for you to keep up to date with what's happening with your EMS data on the national level and what opportunities there are to use it, to learn how to use it, to utilize dashboards and reporting tools and all the other type of supports that we try to provide to states. This would be a great report for you to be able to review. All right, so that is a really quick run through of what's happened with NEMSIS in this last year. I have one more slide. I'll show that real quickly, and then would love to entertain any questions or criticisms or successes you've seen with NEMSIS data. What's our near future look like? Well, really, in the next year, we hope to have these things completed, right? We're currently working with the Office of EMS and NHTSA and actually the Department of Transportation to move all of the NEMSIS IT infrastructure into the DOT instance of the AWS cloud. So that's underway right now. That'll open up lots of avenues for quicker reporting, for researchers to download actual data that they can use for research purposes. It'll really increase the efficiency, hopefully, and the availability of the data for other uses. We've talked about the new approach for data exchange. That should be solidified in 2021 with FHIR implementations. That'll be incredibly important to see. And then the third, I'll just mention real quickly, there has been some great communication with many parts of the federal government utilizing NEMSIS data in incredible ways, right? So just the last couple of weeks, we've been working with the FDA that are really excited to utilize NEMSIS data to determine the effectiveness of medication use in the pre-hospital setting. We collect the medication that's given, the units, the volume, the dosage, and whether or not the patient suffered any consequences of that medication. Did the patient get better or not get better? Once the FDA saw that that was collected on every single administration of the medication, they were incredibly excited to develop a time series data set going all the way back to 2010 to track the value or any side effects they're seeing from medications we're giving in the pre-hospital setting. We talked about CMS with the ET3 project. The Medicaid side of CMS has reached out to us. They'd like to have all legacy NEMSIS data and going forward so they can track opioid abuses to Medicaid patients. Just some great things that are happening, I think, that will increase the vision and the use of NEMSIS data in ways that hopefully will translate into financial support for the system. And then, of course, we would never forget, we have to continue to work on easing the burden of data collection to our providers. And we're actually working hard on that. Folks on this call are probably familiar with our defined lists to limit the number of choices that our providers have to go through to record a symptom or a cause of injury. That's actively happening right now. And our internal board has said, you guys have got to do a better job of making sure clinicians understand the use of this data, what it's being used for, and how valuable it's being on the side of research or on the side of resource allocation. So Lots of great work is going on, and I go to the next slide if you would. I'll yield my time for some questions. Or Eric, if you have other comments that you'd like to share, please feel free.
Thank you, Clay, but I'd really like to hear the questions, comments, or concerns.
And this is Mary Hedges. We're just encouraging folks to type your questions in the chat box, or else you can raise your hand and on your screen, and we can get that question as well. But while we're waiting for that, I'll ask a question, because I know that the big challenge of one of the many challenges of data is the quality of the data and the providers entering it accurately. I know this is a very big question to answer, but what do you see in terms of the improvement in data quality in recent years, Clay?
Yeah, Mary, great question, and that's easy. That's actually easy to answer. When we made them move in NEMSIS from version 2 to version 3, we introduced this idea of the schematron file, where 450 business rules are kind of associated with every completion of a patient care report. And we mandated that all software implement those business rules. And so that if a provider were to fat finger a record and mistakenly report, for example, a pregnant male or something, those are now all caught by these smart business rules and provided to the provider once the record is near complete or complete for them to correct. So, gosh, I wish I had this slide, but the quality of data has just improved so much in the last few years with the implementation of those business rules. We still need to do a better job of presenting them to our providers in a more useful way. And so we continue to work with software vendors to improve their use. Can they real-time logic check? So while they're still on the same page reporting sex, that they can say, oh, well, yeah, the symptom is a problem with pregnancy, and they see immediately that they indicated the sex of the patient was male and correct it on the spot. We're still moving to ensure that all software does that, and it's getting better and better.
Okay, well, that's great to hear. I know, I suppose one of the bigger challenges is just accurate, provider impressions and so forth, which can be rather subjective for the person filling or, entering the data, right?
Mary, the other one that seems to be a challenge is, and it's probably my biggest effort as we move forward with NEMSIS, is to eliminate variation. The disparity in some of the things that are reported and how it's reported, that was the goal of NEMSIS in the beginning. Dr. Mears pointed that out in one of our meetings recently. But we see now that with these defined lists, before we really started to focus on those, how providers interpreted what the response was, or what they should mark in a certain area, or what they should mark in a certain field, and then how things are reported and how it's interpreted. And my goal is, wherever possible, to try to eliminate that variation, so that we're reporting things the same across agencies, across the federal agencies, across states. And that, I think, will help us get a better understanding or better baseline on what EMS is doing. It's almost like the EMS by the numbers gave us the baseline on ILI and COVID. So what's the baseline for normal operations without ILI and COVID? And I think that's where we're heading.
Yeah, and this, Clay, I would just mention, I would love to hear from folks who feel like maybe NEMSIS has not met their needs in regards to data related information. Is there something that's just not yet being done well enough.
Yeah, Mary, I'll echo that. In fact, if we were in person somewhere, I would buy drinks for people who could help us fill in that gap of what those things are. I mean, that's the important part to Clay and Dr. Mann and Clay and Dr. Kramer and myself now is what are these next steps? And that's what we're hoping the internal and external and sort of the subject matter expert advisory boards help us with. But we'd really like to hear that from the actual users from the agency level all the way through the Fed part. Over.
Yeah, well, does anyone want to step up to that question? Be sure and type in or we can unmute you too if you would like to ask the question. And of course, I think a lot of the people on this call are probably not so much the end users, but the inputters. So they may see it a little bit differently. Well, the inputters in terms of at least transferring the data, seeing that the data goes to NEMSIS. They may see it differently than the researchers.
Hey, Mary, this is Joe. Am I unmuted now?
Yes, you're unmuted.
Thank you. Clay and Eric, good presentation. This is Joe from Texas. Just thinking about that last question that you just had, at the local levels, I think, and I know there are some reports already built in, but I'm thinking some of the people may not have, like myself, have the skill level to go in and create reports. If there was just some basic canned reports that they could go to easily, the Joe Schmieder ambulance knows that, the busiest day of the week on Wednesdays at 9 o'clock is the busiest time for call volume, and I see more falls than I do shootings. Some of those canned kind of reports that, as a real beginner looking at some of this data at the very local level, that I could just easily get those reports without having to build stuff like that.
Yeah, that's a great idea, Joe. Yeah, thank you. We actually have that build on slate for this year. We're calling it the Chiefs Monday Morning Report, but basically it's kind of what you're saying, Joe. Just this, oh my gosh, if I'm coming in Monday morning, either at the state level, right, for you, Joe, or for the agencies as well. And I've got my cup of coffee, I'm sitting on my desk Monday morning, I want to see what happened last week kind of thing. We'll reach out to you, Joe, and anybody else who wants to help us with that to ensure that the metrics are what would be valuable in that context, right?
I will add that this is Mary, and we do have a comment from Ann Vosbrink. She says she agrees with Joe's comment. Canned reports like the ones that used to exist in the NEMSIS public cube would be great also.
Oh, great. Okay, great. Thank you. Yeah, that's helpful.
Clay, this is Ann. I just wanted to say, I have to hop on another call, but just the other day, and Monet has offered me a ton of help, but somebody in my office who doesn't have access to our state level data because of restrictions on use for regulation loved one of the former canned reports, asked me to recreate it because they couldn't find it, and I just discovered that it's not currently available in the public cube. It had like fractiles in it, and I just wanted to say, I guess people are using it on their own, and I didn't realize till it went away. So they were very valuable. Thank you.
Yeah, thank you, Ann. When we went to version 3, we had to switch to a different front end for our OLAP cube, but we've recently discovered that there is a way to build those canned reports, and so we will work on that. Thank you, Ann.
So any other questions out there? Now's your chance. Well, this has really been helpful and very, it's always good. It's amazing how far NEMSIS has come, and yet, and to know that there's still much work being done to improve it. So if there are no further questions, Hannah, do you see any other questions or hands up that people that we should give a chance to speak?
No, I don't think so. I think we're good. And I mean, everyone does have control of their volume if they do want to unmute themselves. But Joe just sent in just a big thank you. It was a great presentation.
Yeah, thank you, Mary and Hannah, and thanks, Joe and Ann for the comments. We appreciate the opportunity to be able to update folks. Thank you.
Absolutely. Thanks to all for your participation.
Yes, and thanks, Eric, for your and Dr. Kramer's support of this. It's been certainly a great asset for EMS. Well, and thanks to all for joining us today. And as you know, tomorrow we'll have our special panel discussion on reinventing EMS from 12 to 1:30 and an abbreviated business meeting from 3 to 4 p.m. And the state director's networking session on Friday is by invitation only. So the link was distributed on October 2nd by email. And if you can't locate this and want to participate, please contact Dia Gaynor for further guidance, including a heads up on topics you would want to discuss. So if there's no further questions, we thank you all for joining us. Wish you a great day and hope you join us again tomorrow.
Amen. Good job, everybody. Thank you.